Um, Hello, everyone. Welcome to the Asian Cancer Resource and Support Services Health Talk today. My name is Sienna Fong, and I am the program coordinator with the Asian Cancer Resource Support Services Program, or ACRSS for short. Before we get started today, I would like to give everyone a brief overview of what ACRSS is and what we do. AHSC is the first ever Asian Cancer Resource Center in Oregon that aims to address the full cancer continuum, ranging from prevention, screening, treatment, to survivorship support. Some of the services that we provide include patient counseling, case management, patient navigation, peer support, support group, and much more. All of our support services are provided in Cantonese, Mandarin, Korean, Vietnamese, and English. Our goal is to increase the culturally and linguistically appropriate cancer resources, educational material, and support within the community. To learn more about the specific services that we provide, please view and download our flyer shown here and share it with your friends and community. Please, our flyer will be available on our website. And Cindy will share a link to our website in the chat with everyone. We also have a YouTube channel, which we share educational resources such as these health talk presentations and cooking demonstrations. Feel free to check out our YouTube channel by typing in Asian Health and Service Center in the YouTube search bar. Before today's presentation, there are some few housekeeping items I would like to share with everyone before we get started. As you all may have heard, today's presentation will be recorded, and we ask that everyone turn off your microphone and camera during the presentation to reduce disturbances. Because of that, we suggest that you type your questions in the chat box, and we will gather all of them and have a Q&A session at the end of the presentation. Please note that you'll be unmuted during the Q&A session, and we will also stop the recording once the Q&A session begins. This presentation will be shared on our YouTube channel afterwards with our presenters' permission. If you're interested in viewing today's PowerPoint slides, you can find them on our YouTube channel or request them from our staff. As a side note, our presentation today is scheduled to run until 11:30, 11 o'clock, but we will have a short Q&A session afterwards. With that being said, I'd like to introduce our presenter for today. Today's presenter is Dr. Areo Saffarzadeh from Providence Thoracic Surgery. He is the director of robotic thoracic surgery at Providence Portland Medical Center, and he specializes in the treatment of diseases within the chest, including lung cancer, esophageal disease, and thymus disorders. Instead of reading his bio, I will allow Dr. Saffarzadeh to share his introduction.
Let's see. Okay, can you guys see my screen?
Yes.
All right. Hi there. My name is Areo Saffarzadeh. I'm the director for robotic thoracic surgery at the Providence Cancer Institute. So, just a little bit about myself. I grew up in Chicago and spent some time in California. I did my training at Yale, where I focused on thoracic surgery and minimally invasive techniques. And then here I came up to Providence Cancer Institute to become the director of the robotic thoracic surgery program. And the big bread and butter of thoracic surgery is managing lung cancer patients, and it's something very near and dear to my heart. So I'm hoping to share with you some of the aspects about lung cancer that I think are very important, and hopefully things that are applicable to you guys. We'll talk a little bit about what lung cancer is, some of the risk factors, and some of the treatment strategies that we have. So I'm just going to jump right into it. So you guys can see my screen here, hopefully. Um, so this is a CT scan, and a CT scan is a special type of imaging that we use to look for lung cancer in patients. And these are two different CT scans from two different people, but they share a very similar story. So just so that you're aware of what we're looking at, this is a CT scan of the chest. This is the heart that's in the middle. This is the right lung. This is the left lung. In the back, we have our spine, and in the front, we have our sternum. And I've outlined two different lung cancers in two different patients. Now, both of these patients were smokers. And the patient on the left-hand side, their primary care doctor ordered a special CT scan for him. It was called a lung cancer screening CT scan. And we found this little nodule here that shouldn't be there. And so what we did is we took this patient in for a biopsy. We discovered it was lung cancer. We took out that tumor on the same day. And within 48 hours, that patient went home. The story on the right-hand side here was also another patient who was a smoker, and they never got a lung cancer screening CT scan, even though they should have. And so they eventually started coughing up blood and they had symptoms. And a lot of times for lung cancer, once you have symptoms, it is too late to have a curative type treatment, meaning the cancer has either grown too big or that it's spread. And here, this is probably one of the hardest conversations I have to have with a patient because I have to tell them, I don't think we can cure your cancer. I don't think we can get rid of all the cancer that we can see in your body. And we have to more focus on a control and containment type scenario. And so this conversation is great because it's a easily curable or treatable cancer. The conversation on the right is a lot harder. Now, both of these patients were eligible to get the CT scan, but the primary care doctor here ordered it early for this patient, and here this was unfortunately missed. And so this problem is one that I see over and over and over again. And so my goal has been to get out to the community, reach out to our primary care doctors, and just to let them know how important lung cancer screening is. So the problem with lung cancer, like I was alluding to earlier, is that we want to catch it when it's early, in an early stage. And this is just a graph which shows the stage of diagnosis of lung cancer. So whenever we diagnose a cancer, we say it's stage one, stage two, stage three, or stage four. Stage four is the worst, stage one is the best. When we catch cancer at an early stage, patients are more likely to be alive 5 years later. And so for lung cancer, we're catching a majority of the lung cancer at a late stage once it's either grown really big or it's spread, and just the minority at an early stage. And I always like to compare this to breast cancer, where we do a really good job for screening. And when we compare it to breast cancer, most of breast cancer is caught at an early stage. A minority of it is caught at a later stage. And the main reason is that we do a much better job of screening for breast cancer. And so I would like to see lung cancer become more like breast cancer, where we're catching more of these cases at an early stage. Now, heart disease is the leading cause of death in the United States, but if we look at adults just between the ages of 50 and 80 years old, cancer is the leading killer. And you can pull this data off of the CDC's website, wonder.cdc.gov. And so per decade, 50 to 60, 60 to 70, 70, 80, cancer ends up being the leading cancer, the leading killer. And if we compare all of the different cancer types and the number of deaths associated with it each year, lung cancer by uh, significantly is the leading cancer killer. So if we compare it to colon cancer, lung cancer kills 130,000 people on average each year. Colon cancer is roughly 50,000. Pancreatic cancer, which we know is very deadly, 50,000. Breast cancer, 44,000. Prostate cancer, 34,000. And if you took prostate, breast, and colon cancer combined, it about equals the number of people who are killed from lung cancer. So you would think that we would do a really good job of screening for lung cancer because it's killing so many people. And in actuality, we're not doing that great of a job. If we look at our cancer screening rates, when we look at breast cancer or colon cancer, on average, we're probably screening somewhere between 70 and 75% of those patients. So the number of patients who should be getting screening, who are getting screening, is roughly 3 out of every 4. The data for lung cancer screening is really poor. It's on average about 5%. Now, this data is from an article in 2021, and rates of lung cancer have improved a little bit, but on average, only 1 out of every 20 patients who should be getting screened for lung cancer is getting screened in the United States. And so I pulled this data back in 2021, and this just shows every state in the United States on the x-axis here, and then the percentage of patients who are getting screened. And so if you took everybody and you look at the average, well, the average is roughly 5%. Now, some states do really good, and really good is maybe considered Massachusetts, which is like 15, 16%. And really poor is, like California or Nevada, roughly 1%. But on average, we're doing about 5%. And Oregon here on this graph is roughly 6 or 7%. Now, we have made some progress in improving cancer screening since then, but we have a really long ways to go. And so, because we're not catching these patients early enough, the chance of these patients being alive 5 years after being diagnosed with cancer is really poor. So, if we look at prostate and breast cancer, 90% or more are alive 5 years after being diagnosed with those cancers. But if we look at lung cancer, only 22, maybe 25% of patients are alive 5 years after being diagnosed. And that's because a lot of them are being diagnosed at a later stage. Now, lung cancer screening has not always been the standard of care. So I was very happy to see that the American Academy of Family Physicians, the AAFP, in 2021 got behind the lung cancer screening guidelines and recommended it for all patients who are eligible for it. And we'll talk about who's eligible. But what we learned more recently here is that performing a low dose CT scan, so a lung cancer screening CT scan for high risk people, is one of the most effective ways to reduce lung cancer deaths in these patients. And now, the most effective way is if they are currently smoking, we get them to stop smoking. But after getting them to stop smoking, performing that low dose CT scan is one of the most effective ways. Now, one of the problems with lung cancer screening is that everybody needs to get screened for colon or breast cancer. But for lung cancer screening, it's only high risk patients. And so we don't screen everybody. We only screen people who are considered high risk. So that leads to the question, who is considered high risk for lung cancer? And the answer to this question has changed over time. Back in 2013, when the guidelines first came out, we said, let's screen everybody. There was a big clinical trial that I'll talk about. Let's screen everybody who's between the ages of 55 and 80 years old, who had smoked on average 1 pack of cigarettes per day for an average of 30 years. And they were either current smokers or they quit in the last 15 years. Well, those guidelines got updated in 2021, and what we did is we made more people eligible. And so we dropped the age from 55 down to 50 years old. So anybody between 50 and 80 years old who has consistently been smoking on average around a pack a day for 20 years instead of 30 years. And we just limit that to either current smokers or those who quit in the last 15 years. Now, you might ask me, what is this term we see here? Pack years. So when I said pack year history, what does that mean? Well, it's a way for us to look at how much you smoked for how long. And so the way you calculate pack years is the average number of packs you've smoked per day times the number of years you've smoked. So 1 pack is considered 20 cigarettes. So I'll give you 2 different examples. If you smoked 1 pack per day for 30 years, that would be 30 pack years because it's 1 pack per day for 30 years. Now, if we doubled the amount that we smoked, instead we smoked 2 packs per day, but we only did that for 15 years, that would also be 30 pack years. So it's a way for us to look at how much and for how long, and then take those two things and multiply them by each other. And what we see is that the more you smoke, the higher the risk is for lung cancer. And so our goal with lung cancer screening is to catch the cancer while it's curable. And the way we do that is with that lung cancer screening CT scan that I showed you. And like I said before, if you catch cancer at an early stage before you have symptoms, it greatly increases the chance for cure and therefore for survival. Now, I do like to spend a second talking a little bit more about stage so you can really understand how important it is to catch cancer early. So when we talk about lung cancer staging, like I said earlier, it's between somewhere between stage 1 and stage 4. So stage 1 lung cancers are cancers that haven't spread anywhere. And the most important thing we're looking at early on is has it spread to lymph nodes. So stage 1 lung cancers typically have not spread to any lymph nodes. And if it's really early, your chance of being alive 5 years later is not 25%, like I said earlier. That's for everybody, all combined. If we catch it early, the chance of you being alive 5 years later is as high as 90%, sometimes higher. Now, if the cancer spreads to lymph nodes in the lung, then we're automatically a stage 2 at least lung cancer. And at that point, our chance of being alive 5 years later has dropped down to 50%. Now, if it spreads even further to lymph nodes that are outside of the lung and by the airway, our 5 year survival really starts dropping down. So this represents the airway. Each one of these represents the lung. If it's on the lymph nodes on the same side as the tumor, our 5 year survival is 30 to 40%. If it spreads the lymph nodes on the opposite side, our 5 year survival drops down to 10 to 20%. And then finally, if it spreads outside of the lung or the lymph nodes, that's considered stage 4 lung cancer. So lung cancer tends to spread to the brain, to the bones, to the liver. And when these happens, our chance of being alive 5 years later is really poor. It's 0 to 10%. Now, we do have these miracle stories of patients who are alive 5 years after a stage 4 lung cancer diagnosis. And a lot of this is due to what we call these new targeted therapies. So some of them are considered immunotherapy. We have new drugs that you can take that are just a pill that treat certain mutations. And a lot of that research has actually been done at Providence Cancer Institute. We're one of the leaders in the research of immunotherapy. But our goal here is not to wait. We want to catch it early when it's really treatable, where we can get a cure, where the risk of you dying from cancer is very low. So the data for performing these lung cancer screening CT scans comes from a clinical trial. And it's one of the biggest studies the US has undertaken, where we took 50,000 people who were between the ages of 55 to 74. And these were people who were heavy smokers who didn't have any signs or symptoms or any history of lung cancer. And then we took them and we split them in half and we put them into two different groups. One group got an x-ray every year for 3 years, and the other group got a CT scan of their chest every year. And what we looked at to see what are the differences in outcomes. Can we catch cancer earlier? Do more people survive if they get the CT scan or if they just get the x-ray? And so what we saw from that study is those who got the x-ray versus those who got the CT scan. This is the percentage of people who were diagnosed at an early stage versus those who were diagnosed at a late stage. So those who got the CT scan, 57% of them were diagnosed at an early stage. Whereas those who were getting the x-ray, just 39% of them were diagnosed at an early stage. So getting that annual CT scan, if you're a smoker, increases the chance of being diagnosed at an earlier stage. So that's the difference between this small nodule here and this big mass over here that's causing the patient to have symptoms. And so the end result in all of this is the chance of being alive at the end of the study was 20% higher. Okay? That's a big deal. 20% survival difference just from getting these annual CT scans. I just want to emphasize how important that is, right? Our job, my job is to help people live longer. And so stressing the importance of these lung cancer screening CT scans for my patients, for letting our primary care doctors know, I think is really valuable. And so if you have family members who are smokers or former smokers, it's really important that if they're within that age group, 50 to 80 years old, that they're getting their lung cancer screening CT scan. Now, some people are apprehensive about getting this CT scan. And I like to compare screening from lung cancer screening to other types of cancer screening. And so one number that we look at is how many people need to get screened in order to prevent one death. So the number needed to screen to prevent one person from dying. Because remember, not everyone has cancer when you're screening. These are asymptomatic people, people who have no symptoms. So for breast cancer, it's probably somewhere around 800 screens need to get done before you can save one life. For colon cancer, maybe 1,200 colonoscopies. For lung cancer, the data we see is somewhere between 130 and 320 low-dose CT scans need to be performed to be able to save a life. So it's a very good methodology for saving a life for these high-risk patients. And I just juxtapose this next to the screening rates again. It's such an effective form of screening, and unfortunately, we're not doing a very good job for it. All right, now that I've kind of hammered home this most important point of lung cancer screening, I want to backtrack a little bit and talk about how cancer forms and just give you some background knowledge. So, lung cancer in particular really begins with healthy lungs. Everybody's born with healthy lungs. You have double the lung function you need to survive just from when you're born. But over time, we get these harmful exposures. And so the most common, like I was talking about, is smoking. But that's not the only form or the only cause of lung cancer. There's also something called radon gas, which I'll talk a little bit about more, which is a naturally occurring gas that's found throughout the United States. And there's also pollution, indoor pollution, outdoor pollution, particularly in these Asian countries where females are cooking over solid fuels like coal, we see higher rates of lung cancer. And so these harmful exposures cause DNA damage. And so DNA is the code in our body that tells our cells what to do. And so if we damage that code, we call that a mutation. And oftentimes it's not just one mutation that causes cells to grow uncontrollably, it's multiple mutations over time. So if these are normal cells here that I show on the top, this little red dot shows a mutation, and that causes that cell to divide, but it's not growing uncontrollably yet. And then we get another mutation, and then another mutation over time, and all of a sudden now we have this cells that have lost these signals telling it, hey, don't grow anymore. Because a lot of times our body, we need to grow, right? Cells need to divide, but if it happens but it normally happens in a very controlled fashion. If we lose those signals that tell our body, hey, don't grow these cells anymore, then that's what forms a tumor. And we get a clump of cells that are very similar to one another with these multiple mutations that start to grow. And that's when we need to start treating these lung cancers. So that's how it forms. Let's talk a little bit about these risk factors. As I was mentioning earlier, smoking is one of the leading causes of lung cancer. And in the United States, roughly 80% of lung cancer cases are attributed to smoking. Now, it's not just smoking. Secondhand smoke is also increases the risk of lung cancer by about 30%. So secondhand smoke is, yeah, I don't smoke, but my husband smokes and he does it in the house. And those fumes can cause inflammation and eventually lung cancer as well. So lifetime smokers, if you've smoked for a majority of your life, 1 in 6 out of lifetime smokers will die from lung cancer. But what's important to know that is that if you quit, the chance of you dying from lung cancer will dramatically decrease. And the age at which you quit really matters. So if you quit by 60 years old, roughly 1 in 10 people will die from lung cancer. So we went from 1 out of 6 to 1 out of 10. That's a big deal. If you quit by age 50, that number will drop down to 1 in 20. And if you quit by age 40, maybe somewhere around 1 in 30 people, 1 out of 30 of those people will die from lung cancer. So our goal here is to catch lung cancer early and dramatically reduce the deaths from it. Now, everybody always asks about vaping. Vaping is very new, and we don't have much data to support. Uh, we don't have much data right now to support whether vaping causes lung cancer. There's a lot of suspicion that it does. We know vaping damages the lungs, and when lungs are damaged, that it might increase the risk of lung cancer. But we need really long-term data before we can determine that. Now, the other risk factor, which is something called radon gas. So this is naturally occurring, and radon gas is odorless. You can't smell it. It's invisible. You can't see it, but it's a radioactive gas that is found throughout the United States, and it's released from rocks and soil and the water. And within people's homes, you might have cracks or little gaps in the foundation. And so this gas, as we can see in this picture here, kind of works its way up and it gets trapped in the basement most of the time of many homes, and it builds up over time. And what we've come to find is that radon is actually the leading cause of lung cancer in non-smokers, and it's the second most common cause in smokers overall. And so I really encourage people to check the radon levels in their house. And the EPA has a cutoff where they say, hey, you need to do something about the radon levels in your house if it's above 4. Now, the units for that are not important, but it's the number that we're looking for is that 4 number. And so this is a map of the radon levels in the Portland area. So green means low radon levels, yellow means kind of moderate, and red means high. So, but this isn't totally just because you're in a yellow area doesn't mean there aren't little spots up here that could be red, but this is kind of averages based off of a limited number of houses that they looked at. So whenever people buy a new house, it's really important that you check the radon levels. But if you've been living in a house for a while and you don't know if the radon levels have been checked, it's really important that you check them. And how can you check them? Well, if you go to the American Lung Association's website, you can purchase a radon kit. You can also go to your local Home Depot. They're somewhere between 10 and 20 bucks. You can order that, and these are available in stock to be picked up. And so that allows you to get a sense of what your radon levels are. Now, if your radon levels are high, what should you do? Well, we get a radon mitigation system. What does mitigation system mean? Essentially, it's a system to get rid of all of that radon gas that might be trapped in your basement or underneath your house. And so essentially, it's a pump and a fan, and we just pump that radon gas out so it doesn't get trapped in the basement and accumulate over time. And this is what it looks like on the outside of a house. It's just this little pump system, and it just pumps it straight up and out. I really want to stress how important it is to check the radon levels in your home if you haven't done so already. Now, we have lots of different types of lung cancer, and broadly speaking, and these terms aren't very important if you're new to it, but we separate lung cancer based off of what the cells look like when we look at them under the microscope. And so if the cells are really small, we call that small cell lung cancer. And if the cells don't have that particular shape of small cell lung cancer, we call that non-small cell lung cancer. Small cell lung cancer is very deadly, and it comprises about 15% of lung cancers. And then non-small cell lung cancer, there's really two major types. One is called adenocarcinoma. This is cancer that forms in the glands, typically near the ends of the airway. And then we have squamous cell carcinoma, which is cancer that forms in the lining of the lung. So kind of ignore all the details here, but this is just showing the inside of your airway. And so if it forms in these kind of basilar cells that line the airway, we call that squamous cell. And that's and then if we see it near the end of the airway, near where these glands are, we'll call that adenocarcinoma. And this just shows how these look differently on slides. And then finally, these are just different mutations. Remember when I talked about the mutations earlier that are associated with these different types of cancers. You don't need to memorize any of this, but I just kind of wanted to point that out. So, hypothetically speaking, let's say you get a lung cancer screening CT scan and they find a nodule. How do we treat that nodule? How do we diagnose it? Well, number one, and how do we treat it? And over time, that answer has changed. And I'm going to talk about what I personally do for these lung cancers. And a lot of that involves robotic techniques. So there are two main robots that I personally use in the diagnosis and the treatment for lung cancer. One of them is a robotic bronchoscope. So it's a robotic camera that we can guide into the airway to biopsy lung cancers. And the other one is a robot that we use to cut out lung cancers during surgery. And I'll explain a little bit about them here. So for a bronchoscopy, which is a camera that we put down the airway, we need to know exactly where that tumor is. And so we get a special CT scan for these patients. And we put that CT scan into this computer and it makes a map of the airway. And it tells us exactly how we can get to that tumor. So here's a video here that shows it's showing us the airway, and the pathway that we need to take in order to get to this tumor here that's at the end of the airway. Now, if I was looking at this from the outside, it would look really challenging. And so to help me when I'm in there, the CT scan that we use also creates a map pretending that we're inside the airway. And that's what this map is here on the right side. And so for me as a surgeon, I just have to follow this blue line when I'm inside the airway, and it'll tell me exactly where to go within a few millimeters. And I just need to biopsy it with a hollow needle. So this is that blue line that I need to follow. This is the airway on the left side. This is the airway on the right side. I just need to follow this blue line all the way down. And eventually, if I follow that line, it'll get me exactly to where the tumor is here in that light blue color. And so then once we get there, we perform a biopsy. What is a biopsy? Well, that camera took us to where this tumor is. Now we need to get a little piece of it. And the way we do that is that long catheter, that long camera, has a small hole all the way through on the inside. And through that hole, we can put a long hollow needle and we can stab the tumor with the needle. And so this is what it looks like. We're inside the airway. This is the camera that's there, but then this is that needle that comes out, and we stab the tumor and we get those cells. Once we have those cells, we can look at it under a microscope. And the person who looks at it under the microscope is called a pathologist, and they determine if there's cancer or not. Now, if the pathologist sees cancer, then we need to take it out. And we use robotics now to take it out. Let's talk about what robotic surgery is. So this is a video from that Daryl Pearlstein made on his website, Robotic Thoracic Surgery. And I think it's very instructive. So this is where the surgeon sits. I sit at a console. And it's important to remember that the robot doesn't do anything on its own. I'm controlling every aspect of the robot. But the robot here is docked, it's connected to the patient, and there's 4 different arms that the robot has to do its work. So this is where the surgeon sits, it's connected to the robot, and there's 4 different arms that we use. One arm is a 3D camera that allows us to see in 3D inside the chest. Another arm we use is to kind of push things out of the way so we can see where we're working. And the last one is 2 instruments. Now, whenever I move my wrist, the robot moves its wrist. And whenever I open and close my fingers, the robot will open and close its fingers too. And this is exactly how I control it. I've got 2 hand controls, and then I have a bunch of pedals down here where I can control if there's electricity, to cut or burn things inside the body so that we don't get any bleeding or stuff like that. And so just to kind of highlight it, this is where the surgeon sits. I'm looking in this view. I get a 3D view, so there's a view on each side. And the benefit of having a 3D view is that we can have depth perception. We can see how far away or close something is. And then these are the instruments here, where when I open and close my hand here, it opens and closes the hand of the instrument. Now, I always like to contrast this to what we did previously. So when we do this minimally invasive surgery, we just have a bunch of small holes, similar to how we see here. This is what surgery was in the past. We'd make a big incision, we would spread the ribs, and we'd have to get our hands in there. And then that evolved to what we call VATS, which is video assisted surgery, where we would put a regular camera in there and we had these long, straight instruments. Robotics took it to the next step where we have a 3D view inside the chest. And here on the instruments, I say that we have wristed instruments, meaning it has a wrist that you can bend right at the end. You don't have to work with straight instruments. And this allows us to get into tight places. And so I'll show a little video here. So this is an actual lung surgery. This is the lung. And we're going to push the lung out of the way a little bit. This is inside the chest. This is what the lung looks like when there's no air inside of it. And so here you can see these are the instruments, and they can be open and closed, and you can bend them at the wrist, and then you can use a little bit of electricity to divide some of this tissue. Here is a lymph node that's part of your immune system. And during the surgery, we have to check multiple lymph nodes. Because remember, if there's cancer in the lymph nodes, it increases the stage of the surgery. So this is just showing you how well you can work in this really tight space to find this little lymph node right here and take it out. That's just one of the many parts of this surgery. Now, sometimes we'll use both of these robots together. So I'll use the camera to go find where that nodule is. If it's a really small tumor, it might be hard to find during surgery. And then I can inject a little bit of dye. And I can see this colorful dye when I'm inside the body to know exactly where I need to cut out. So if I was just looking at the lung by itself, it's hard to know where the cancer is. This could be the cancer, that could be the cancer, that could be the cancer. But if beforehand, if I mark it with a special dye, then I know, hey, this is the portion where the cancer is. Let's cut out this portion of the cancer only. And the end result with these new techniques is for faster recovery. It's for more precise biopsies, more accurate biopsies, better surgery, faster recovery. And our goal is really to get patients home and back to work sooner. Now, surgery isn't the only treatment that we have, it's the standard of care. And so when we do surgery for lung cancers, we can cut out just a small portion depending on the size of the cancer. We can cut out a whole lobe, and very, very rarely do we ever take out the whole lung. This used to be more common, but now it's not common at all. Now, for patients who can't get surgery, if their lungs aren't healthy enough or they have a lot of other medical issues, we have something called radiation, where we can use multiple radiation beams and focus them on one point and zap this area. And there's also something called ablation where we can use needles and use either freeze the tumors or use microwave therapy to kind of burn up these tumors. And that's another therapy that's out there. Finally, here, I just wanted to summarize and then open up the floor for some questions. And the key points here is that lung cancer is one of the leading cancer killers. Smoking is the biggest risk factor, followed by radon exposure. Cancer forms when you have these harmful exposures, which lead to mutations that causes these cells to grow uncontrollably. Quitting smoking is the most important intervention for you to live longer, but after that, lung cancer screening is the next most important. And the people we screen are either current or former smokers who are between 50 and 80 years old. And finally, the technology for biopsy and treatment has really improved significantly over the last 5 years. All right. That's all I had to say. I wanted to kind of open it up for some questions.